session. Thank you.
Okay, so I understand we're coming towards the end of the meeting, so I'll be quick here, and I promise that I will finish before my allocated time. So this is a gentleman who came into us with a unstable angina. He's diabetic. His echo was unremarkable. This is his diagnostic. You can see a tight lesion in the RCA. And you can see a proximal LED lesion with a good circ. And you can also appreciate here that he has a CTO of the, maybe you can call it a dual LED system, but you can see that CTO is like there is an angle that that CTO is coming at. So with that, we discussed with him, of course, we did this is another view of the LED. And we did IVUS to confirm that the proximal LED was significant. So we have diabetic with at least 2 vessel disease. We discussed with him surgery, but he declined. So we had to do something about his coronaries. And this case, it highlights some of the points that have been already discussed. So to the fans of DCB out there, we went with a, I don't know if you call it DCB or DEB. That's a discussion that we've never tackled today. But we went with a DEB or DCB 3.5 with reasonable results. So at this point, I was happy with the RCA, and we shifted our attention to the LAD CTO. Unfortunately, we could not tackle that CTO as it coming out of at a significant angle. We didn't have an angled microcatheter to aid for penetration. So at this point, would you still tackle the proximal LAD or just call it a day and leave it? Maybe for the panelists, if they have any opinions.
Anyone? Musanna?
Sorry?
Musanna, Muhannad, anyone will deal with LED or finish?
Sorry, I didn't see the original angiogram. I'm not sure. But there was a cross-filling. When you opened the RCA, there was a cross-filling to the LAD. So that tells me this, the lesion. When you had your last image from the RCA, there's septal going to the LAD, which tells you it's severe disease, but I haven't seen the original.
So there's a mid-LED occlusion on a steep angle. I think I would fix the proximal LED. The distal LED is a CTO. If the patient becomes asymptomatic, you can completely either defer or reconsider the value of that CTO PCI based on the risk.
Okay, excellent. That's what I did exactly. So I went after the proximal LED. My plan was to balloon it and see what's happening, if we can DCB it or stent it. And this is the 3.0 compliant balloon. And if you can see the image after the ballooning, you can appreciate there's some dissections. So I wasn't comfortable with just DCBing that segment. So I decided to stent and nail the ostium. And we already talked about how difficult it is to nail the ostium. You can appreciate the small dissection in the proximal LAD. The circ was big, and I didn't think it needed wiring at that point. So maybe I'll stop here and I'll tell you there is a complication in the next slide, and I would leave it to your imagination to think, what is that complication going to be?
Sure, please. You have time, 5 minutes.
Yeah, I'll finish.
You can
before.
go, please. Yeah. Just remind you.
I promise to finish before my time.
So, I mean, I don't know, but you've said there's a dissection in the proximal LAD?
No, you can see the dissection in the, before placing the stents there.
Yeah, sometimes you get a hematoma in that area, and we put the stent, you could paste it backward or forward. And what size stent? 4.0. This should take a 4.0. It's a big artery. So I'm expecting maybe if there's a hematoma, you might have pasted it back toward the left main.
Yeah, that's exactly right. So after stenting, we can see pinching of the ostium of the circ. I remember we did IVUS, and the diagnostic, and the left main and the circ were not involved with this atherosclerosis. So pinching the circ, patient is having chest pain. So I went and decided to do kissing ballooning here. Patient was still having chest pain, took a picture, no improvement. So decided to go ahead. And you can appreciate actually the staining of the contrast at the ostium of the circumflex. I thought this was a transmitted dissection / hematoma from the ostium LAD into the circ.
And sorry to interrupt you, the stent did not come back to the left main, did it?
I thought it did not come back, or at least I hoped it did not. So I thought I nailed the ostium. But of course, there was no time to do IVUS at this point because the patient was having ongoing chest pain. So now we had to tackle that. Of course, you can see clearly the section. I stopped injecting after this picture and decided to go with I don't know if it's the right terminology, but a nano crush technique. So placed the stent into the circ, removed the LAD wire, and then recrossed and kissed and pot with a 5-0 and ended up with this results. So basically, my case demonstrate use of DCB in the RCA, abandoning a CTO after some time, and fixing the proximal LAD with a dynamic decision-making strategy.
Excellent. Thank you very much for sharing the case. So.